This is TTT Live. I'm DK Rostar. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, and on Facebook at TTT Live Online. We go now to the Manager of Corporate Communications at the Ministry of Health, Candice Alcantara.
Good morning. We are pleased that you have joined us again for the Ministry of Health's virtual media conference, which provides an update on the Ministry's COVID-19 strategy. Here to share the latest COVID-19 updates with us are the Honorable Terence Dayalsing, Minister of Health, Dr. Roshan Parashram, Chief Medical Officer, and Professor Christine Carrington, Professor of Molecular Genetics and Virology at the University of the West Indies Faculty of Medical Sciences. I am Candice Alcantara, Manager Corporate Communication at the Ministry, and I will moderate this morning's media conference. We go straight to Dr. Parashram, who will deliver today's clinical and epidemiological update.
Hi, good morning, Ms. Alcantara. Morning to Honorable Minister, morning to Professor Carrington, members of the media, members of the viewing and listening public. So I'll begin with the clinical update as of March 14, 2021. Data compiled as at 4 p.m. Total number of tests to date are now stand at 101,952,000. Our positives over the last 24 hours are now 14, taking our total positive caseload up to 7,783, with a total number of recovered persons being 7,531. Active cases now stand at 112. Persons in hospital are at 5, and those who have died are at 140 at this point. In home isolation, we went up a little bit to total persons in home isolation 90, those in state quarantine 297, and those that stepped down 3. With regards to hospitals, our hospitals are remaining very low in terms of their numbers. All 5 patients are at the Couva Hospital and Multi-Training Facility. No one is on ICU or HDU at this time. Our step-down facility being utilized at this point is the UE Debe campus, has all 3 persons. With regards to quarantine, they are spread amongst a number of facilities. The Cape Buck Hotel having 100, Canada Hall 35, Chancellor Hotel 20, Regent Star 29, Paria Suites 18, Tradewind Hotel 18, Canada Hall 12, Napa 12, and UTT 12. Just to correct, the 35 persons were actually at the Cascadia Hotel. Our overall occupancy is 19% throughout the system. Hospitals at 2%, ambulatory 3%, no one in ICU, no one in HDU. If I can have my first slide this morning. Yeah, so just a brief epidemiological update. So we can go to the second slide. Our focus being just on this slide, and then I will focus a little bit on the last slide. So if you look, and this is our continuous epidemic that has been going onwards, we want to focus really on the furthest right-hand side. And what we saw is that over the last 3 or 4 days, they have been reported over the last 24 hours. First, we had 7, then we had a spike of 10, and now we have 14 over the last 24 hours. So in that orange color, way on your right-hand side. Prior to that, we have been hovering anywhere between a 7-day rolling average of 3 or 4 for upwards of close to a month or more. Those cases, we will go into a little more detail if I could have the next slide. Again, just to give you an idea of the sex distribution and the age distribution over the entire period. Again, we have males 53.2%, females 45.5%. Our total age breakdown, less than 25, we have 17.3%, 25 to 49, 55.2%, accounting for the majority of the cases throughout the epidemic. 50 to 59, 13.7%. Above 60, 13.8%. Next slide. So again, this is the relation and the disaggregation of deaths by age and sex. Again, and which has been the case throughout the epidemic. Males predominate in terms of deaths, 74.3%, females 25.7%, although the infectivity rate has been very equal throughout the epidemic. Those less than 50 are 13.5%, 50 to 59, 16.4%, 60 to 69, 26.5%. 70 to 79, 27.2%, and above 80, 16.4%. Last slide. Yeah, so this graph is what I wanted to highlight the situation over the last few days. So when we would have provided this update maybe last week, we would have seen all of Caroni having maybe just a couple orange spots. Now we can see where we have no cases in the River Mayaro, for example. Tobago is very cool by way of hotspots. St. Patrick has very low number of cases. Where we want to focus is we want to focus on Caroni in the middle. So we're seeing orange and we're seeing some darker hues. Those last few cases actually came, all of them from County Caroni, where we would have had 2 or 3 major clusters setting up, and those clusters would have been possibly involving 2 families, places of work, and we really saw that from one individual being infected, that one person was able to spread it for quite a large number of people in a short space of time. Hence our reason for getting our rolling averages now up to 7 within the space of a few days. And we actually have that clustering occurring where we can see not necessarily geographically linked in small spaces, meaning not on the same street, not on the same household, but we're seeing linkages in terms of workplaces, in terms of places where persons go to congregate, and we need to remain vigilant at all times. We are listed in Trinidad and Tobago as having community spread, and we have not changed that designation for quite a while now. When we look at the classification from WHO, we are somewhere where we can be categorized as low community spread. And this incident or incidents that we are seeing in Caroni is reason for us to continue to maintain our public health vigilance throughout the country. COVID-19 is here. It is in the country. It hasn't gone away. And there has been a little complacency over the last couple of weeks because of the low numbers in my view. And I think this small upsurge in cases shows that although the numbers are low, you can still have clusters of cases and larger outbreaks occurring at a local level very quickly and taking those numbers very high in a very short space of time. So just to highlight the situation in Caroni, letting everyone know that we need to maintain the vigilance that we have been doing for a long period of time. And once we maintain the vigilance, continue wearing our masks and continue following the public health measures, we could once again contain this small outbreak. I've been working with the CMOH for County Caroni, the CEO of Southwest Regional Health Authority, Dr. Hines' unit, the GIS unit, on the ground to actually have all the primary, secondary, and tertiary contacts quarantined. We are testing up to primary and secondary in those instances to ensure that we maintain and control this particular outbreak in County Caroni. Candice, that's my clinical update for this morning.
Thank you very much, Dr. Parasram. And we go now to Professor Carrington, who will give us an update on the variants.
Thank you, Ms. Alcantara, and good morning to Minister Diyal Singh, Dr. Parasram, members of the media, and members of the viewing and listening public. Over the past year, there have been some amazing discoveries, scientific discoveries, that have led to us having a much better understanding of SARS-CoV-2, the virus that causes COVID-19, and on how to detect, treat, and prevent COVID-19 itself, the disease. But most importantly, we now have several safe and highly effective vaccines that are available around the world. Now, these vaccines have between about 62 to 95% efficacy against COVID-19, meaning that you will see a 62 to 95% reduction in COVID-19 cases in vaccinated people compared to unvaccinated people. And that is across the spectrum of COVID-19 disease. So in that case, we're looking at very mild disease all the way to severe disease. If you consider only severe disease that results in hospitalization and death, then the vaccines are almost 100% effective. For example, in Scotland, they have shown that the risk of hospital admissions fell by 94% after the Astrazeneca vaccine was rolled out there. Also, very importantly, there is evidence that the vaccines prevent transmission. We're getting more evidence of that. And that means that it will prevent transmission from person to person. So that is a very important new set of information that we have. Now, as a result of all this, there has been a dramatic drop in the number of new infections, in the number of hospitalizations and deaths in vaccinated populations. However, one of the concerns that has arisen is the emergence of so-called variants of concern. that either spread more quickly from person to person or result in reduced vaccine efficacy. And I'm going to focus on how those variants arise and their impact. So we have to roll back a bit. So when a virus is transmitted to a susceptible individual, it enters their cells and it replicates to produce millions of new virus particles. Now, during this process, millions of copies of the virus's genome are made. That's the virus's genetic material, and so that each new particle will have some of that genome incorporated into it. The genome, as we know, is like a set of instructions, a sort of instruction manual containing all the information to make a new virus particle in the next cell that it infects. So during infection, every time a copy of the genome is made, errors can be made, and those errors are called mutations. Mutations are normal and they are expected. They are the basis of evolution, and viruses evolve very quickly. They mutate and evolve very quickly. So when you have a virus that is widely circulating in a population and causing many infections, the likelihood of the virus mutating increases. This is because the more opportunities that the virus has to spread, the more it replicates, and the more opportunities it has to undergo changes. Now, a technique called genome sequencing can be used to detect and track the mutations that occur, and genome sequencing studies have shown that over the past year, many different lineages of SARS-CoV-2 have emerged, and so you have different, slightly different versions of the virus that are differentiated from each other by numbers of mutations. A virus with one or more mutations is sometimes referred to as a variant of the original virus. So that's where we get the term variants. Now, it's important to note that the vast majority of mutations have little or no effect on the virus's ability to cause disease or infection. But occasionally, you do get mutations arising that affect the virus's properties. For example, you can get mutations that might cause a virus to spread more easily or less easily from person to person, or to cause more or less severe disease. Or you might have mutations that might influence the way that the virus interacts with the immune system. Now, as mutations accumulate over time, it becomes more likely that we will start to see variants with new properties, some of which may be of concern. So after a year of this virus evolving, that's what's happening now. We're starting to see more and more variants, and some of them are of concern. There are currently 3 major variants of concern. They're called B117, B1351, and P1. Very cumbersome names, but you might know them as the UK variant, the Brazilian variant, the South African variant, and the Brazilian variant. And they are characterized by specific groups, or what we call constellations of mutations, as that sort of give them new properties. There are also a number of other variants that are under investigation, or they are of interest because they carry some of the mutations seen in the variants of concern. Now, coming to these variants of concern, B117, which was first detected in the UK, it is most notable for being at least 50% more transmissible than other lineages, meaning that it spreads more quickly. And there is also evidence that this variant causes more severe disease. Now, using genome sequencing, we detected this variant in samples from 7 Caribbean countries, in some cases, unfortunately, associated with rapid community spread. So it's actually in the community in those countries. In Trinidad and Tobago, however, we have only detected that one sample with the B117 variant in it, the UK variant, and that was reported in January, and thankfully that was in a quarantined individual and not in the community. So our mitigation protocols are doing their job. Now, the next one I want to talk about is B1351. That is the one that was first identified in South Africa, and also P1, the third one, which was first identified in Brazil. Now, they are of concern primarily because there is evidence that they are able to reinfect people who were previously infected with a different variant, a non-variant of concern, and also that the vaccines have reduced efficacy against them. There is also some new evidence to suggest that in the case of P1, the Brazilian one, that it is more transmissible as well, like B117. However, this still has to be confirmed. Now, although these variants, against these variants, the vaccines are not as good as preventing in preventing disease altogether, the evidence suggests that they will still work well against these variants to prevent severe disease, which is the most important thing. So they'll prevent severe disease, hospitalization, and death. So even where these variants are detected, it's of course still worth getting vaccinated. Now, we have not detected B1351, the South African variant, in any of the samples that we've looked at from across the Caribbean. But as was reported by the Chief Medical Officer some time ago, we did detect P1, which is the Brazilian variant, in a Trinidad and Tobago sample. But thankfully, the sample was from an individual who was on a boat and who was not allowed to disembark from that boat. So again, this emphasizes the importance of all the public health restrictions that we have, the border restrictions, and the quarantine protocols that we have in place. So as I indicated before, in addition to these variants of concern, there are other variants that are under investigation because they contain some of the mutations that are found in the variants of concern that I mentioned. Now, you may have heard recently about one of them identified in the UK in travelers from Antigua. It is called B13241, and it contains mutations that are associated with both higher transmission and lower vaccine efficacy. However, we have to remember that the mere presence of these mutations is not enough to conclude that the variant shares the same properties, because those mutations occur in a context. So the context in which they occur, the rest of the virus's genome is important. And it is also missing other mutations that are thought to be significant. So it's under investigation. So hopefully we will know soon if it is a variant of concern. So one of the important things that people keep asking is there a way to prevent mutations and to prevent new variants from arising? And the answer to that is yes. Now, since mutations only occur when viruses replicate within the cells of an infected individual, the way to prevent mutations and the way to prevent variants arising is to prevent new infections. For COVID-19, this is done by wearing your mask, social distancing, avoiding mass gatherings, border controls, etc. All the things that we have been doing over the past year. Now, the longer this pandemic goes on, the more chances there are for SARS-CoV-2 to mutate. So we just have to double down on all the things we've been doing for the past year, because we really want to keep these variants at bay. There is also a growing body of evidence that in addition to protecting against disease, the COVID-19 vaccines reduce person-to-person transmission, so they can help to prevent transmission. So vaccines have an important role to play in this regard as well. We should also remember that the COVID-19 vaccines are expected to provide at least some, I just want to end on this. The COVID-19 vaccines are expected to provide at least some protection against the new variants, especially when it comes to severe disease. And that is because the immune response that they elicit is a broad immune response involving a range of antibodies and a range of cells. So the changes and mutations in the virus should not make vaccines completely ineffective. And as I said, they will work well against severe disease in particular. Now, in the event that any of these vaccines proves to be less effective against one or more variants, there is another alternative. It is also possible to change the composition of the vaccines to protect against the variants. So there are several studies now underway to develop variants of the vaccines to tackle the new variants of the virus. Thank you very much.
Thank you very much, Professor Carrington. And we go now to the Honorable Terence Deyalsingh, Minister of Health, for a statement.
Good morning. Good morning, Candice. Good morning to the Chief Medical Officer. And good morning to Professor Carrington to remind us that we must keep up with the public health measures. Good morning to ladies and gentlemen of the media and to all those listening and viewing. My purpose here this morning is to put on the table for public consumption and that of the media the facts surrounding the government's vaccination plan and our vaccination objectives. Because in this era of misinformation and disinformation, the government's vaccination plan is being misconstrued, it is being ripped apart and reconstructed by those who should know better to give a narrative designed to breed ill confidence or no confidence in the government's vaccination plan. And that is unfortunate. So I am going to go into some detail this morning of what is the government's vaccination plan based on policy and based on science and based on evidence. The government of the Republic of Trinidad and Tobago on September 18th, 2020, which is about 5 to 6 months ago, signed the COVAX agreement. That was the beginning back in September 2020 of the government's vaccination plan. In that vaccination plan, and this is where people are misconstruing the numbers, the cabinet note spoke to WHO's objective of using COVAX to vaccinate 20% of the world's population, or of the countries that signed up to COVAX, 20%, to end the acute phase of the pandemic within 1 year, or hopefully by the end of 2021. That is where that 20% comes from. The cabinet note went a bit further, that we will seek to source through COVAX enough vaccines to vaccinate 33% of the population, outside of the initial 20%. So 20% is 240,000 persons, 33% is just over, I believe, 500,000 persons. That is what the cabinet note spoke to on COVAX. In addition, the current science speaks to a country that, or the world, if you want to achieve herd immunity, you must vaccinate somewhere between 50 to 60 to 70% of your population. This is outside of COVAX. We have said this consistently and clearly over the past few months. 20% is COVAX's initial target. The cabinet note also goes on to ask COVAX for vaccines to cover 33%, and herd immunity is somewhere between 50, 60 to 70% in that range based on the current science. Outside of COVAX, Trinidad and Tobago began formal bilateral talks on October the 1st, 2020. Note the word, formal bilateral talks. We were in preparatory talks before that. Before you can talk to a country or a vaccine manufacturer, they have to be willing to speak to you. So we were making approaches prior to October 1st, but formal talks began in October 1st, and they continue up to the present with countries and also vaccine manufacturers who to date have all told us they are not selling vaccines to third parties or private entities. They are only dealing with governments. Other approaches are being managed through the CARICOM Secretariat, which manages the African Medicines Council's platform. So that is the negotiations. What is TT's vaccination plan? Because commentators and certain opposition leaders are pointing to other countries that have started their vaccination plan and why we have not started as yet. We have said from day one that Trinidad and Tobago, as per protocol, will only be allowing into the country vaccines approved by WHO once they get EUL or EUA, which is Emergency Use License or Emergency Use Agreement. We must note that when we are compared to other countries that have started their vaccination programs, many of these countries, as is their right as sovereign states, are using non-WHO approved vaccines, and we could have absolutely no problem with that. So we are not comparing like with like, we are comparing apples with oranges. Let me reiterate, Trinidad and Tobago will only be using WHO approved vaccines, and we note that other countries have started their vaccination program using non-WHO approved vaccines, and that is their right as a sovereign state. The Trinidad and Tobago model for managing COVID by all objective measures has proven to be successful. We have saved lives, we have saved livelihoods, and we are a country where most sectors of the country are in fact open. The vaccination program, which Trinidad and Tobago has used for over 50 years in Trinidad and Tobago, has proven to be successful. And one of the key success factors in 50 years of vaccinating people is that people must have trust in the vaccine. This tried and proven method of using WHO-approved vaccines has served us well for 50 years. You would have heard one of the nurses who was here a couple of weeks ago said, in her 10 years of administering vaccines, she has never had to fill out an adverse event form. And that is why I am confident that once we start to vaccinate persons on this tried and tested method for 50 years, it is going to prove successful. What are some of the constraints? How many vaccines have in fact been approved by WHO and when? Because these are the constraints now. Where are we now? The Pfizer vaccine, which was not originally a part of COVAX, we must remember that, and we have said that several times. The Pfizer vaccine got approval on December 31st, 2020. So as far as the COVAX facility is concerned, Pfizer has only been available 2.5 months. The Oxford Astrazeneca vaccine only got approval on February 15th, 1 month ago. And the Johnson & Johnson vaccine got approval on 12th March, 3 days ago. So I want all those who are intent on creating mischief and misleading the population, I'm speaking directly to the population now. The vaccines approved by WHO, Pfizer approved 2.5 months now, December 31st. Oxford AstraZeneca, which we are expecting in this country, on February 15th, only 1 month ago. And Johnson & Johnson, 3 days ago. So that is where we are in the lineup of having WHO-approved vaccines. But the population also needs to understand, and we have said this before, that WHO not only approves the vaccine, as per normal new drug registration process in Trinidad and Tobago, they also approve the sites of manufacture. The AstraZeneca vaccine is being manufactured in many plants around the world, United States, Europe, South Korea, and so on. WHO has only approved 2 sites under the COVAX facility for the Astrazeneca vaccine. So that's a further limitation. Those sites are the Serum Institute of India and SK Bio, South Korea Bio. It is our information that the vaccines we will be getting under the COVAX facility, hopefully by the end of March, are coming from SK Bio, the South Korean plant. The reason why I'm going into such detail is that the population must understand the due diligence that both Trinidad and Tobago and WHO engages in to make sure that the vaccines that we supply to persons to go into your arms are safe and efficacious. Let me repeat that. AstraZeneca has many plants around the world. I could source AstraZeneca vaccines today from many plants around the world. You would have noticed, although no link has been made, that some European countries have suspended the use of the AstraZeneca vaccine because of certain batches manufactured in Europe. But to date, there is no link, and that is good. But could you imagine if I, as Minister of Health, advised the government to bring in any vaccine from a plant that is not visited by and signed off by WHO, and similar concerns were raised locally? Whilst I know we are all anxious, and I am anxious, safety of our local population must trump expediency. What is our operational plan now to vaccinate persons once we get WHO approved vaccines from sites that are approved by WHO? Our policy is a stratified one based on persons having high risk and high exposure. So therefore, in the first instance, when vaccine supplies are limited, we will be prioritizing certain groups of individuals based on their exposure and their risk. This is the eligibility criteria we are going to use. It is the equitable thing to do. But before we go there, a vaccination plan operationally has to be based on where you are going to store hundreds of thousands of vaccines. If you don't have storage capacity, you can't vaccinate persons. I would have told the country late last year that we were going to build a chiller in Couva. I am happy to report I paid a visit, my last visit to Couva. I was there a couple of times during construction. I was there on Saturday. Construction has now been completed. And that storage facility can store 1 million doses of vaccines. 1 million. We never had that capacity before. This is part of the operational plan now. At C40, we can store 120,000. At the Arima Hospital, 120,000. At Point Fortin, 120,000. And at Tobago, 60,000. So we now have the capacity to store 1.4 million doses of vaccines in Trinidad and Tobago. That is no small feat. In addition, you must have the consumables to go with your vaccination plan. Right now, we have 1 million syringes in stock. We have another million coming in on April 30th. There are lots of moving parts to launch a vaccination plan. We have 1 million alcohol swabs and we have printed an extra 40,000 vaccination cards. So when the vaccination process begins, all consumables are in place. So 1 million syringes now, another million coming in up in April 30th, and 1 million swabs. This is all in effect to put together a robust vaccination plan. To vaccinate people, I would have gone into some detail about 2 weeks ago. We have already identified 21 vaccination sites throughout Trinidad and Tobago. I wouldn't list each one. We have it up on the Ministry of Health's website. But just to remind, they are distributed amongst the 5 RHAs as follows. Tobago RHA, 3 sites. ERHA, 4 sites. North Central RHA, 4 sites. Northwest RHA, 2 sites, and we are looking at possibly more. And Southwest RHA, 8 sites. So your vaccination plan is predicated on having vaccines, having consumables, and having the physical sites. We have already begun the sensitization and resensitization of the vaccinators. That is, the persons to administer the vaccinations. And we are engaging more HR personnel. Our IT platform to manage this is up and running, and we have repurposed our hotline so that once we start to vaccinate persons, you have a hotline dedicated to that. Many people are asking, when will I be vaccinated? So, based on the policy, and everything must be driven by policy, science, and evidence. Based on the policy, science, and evidence, we are vaccinating people, as I said before, based on high risk and high exposure. So, in phase 1, which has begun to a certain extent with the gift from Barbados, we have vaccinated to date 1,113 or 120 frontline healthcare workers. But when we get in that shipment of 33,000 odd, hopefully by the end of March, we continue that. Then we vaccinate the elderly in the long-stay homes. We have already received permission from them to vaccinate roughly, I believe, 987 CMO, thereabouts. Let's just say 1,000 to round off the figures, because they are high risk, high exposure. And then we start to vaccinate those with NCDs, non-communicable diseases, because, as the science and the evidence will tell you, the vast majority of the 140 persons who have died have comorbidities like diabetes and hypertension. So you will get the most bang for your buck if you go after these 3 initial categories. In phase 2 of the vaccination plan, we go after essential workers, as I have indicated before. And the list is not exhaustive. I will just give you some idea who we consider essential workers. These are persons that keep the organs of state and the organs of the country alive and well. So frontline police, Coast Guard, Army, the teachers who are out, not all 13,000 teachers, but the teachers, high risk, high exposure, who are now out in classrooms, forms 4, 5, and 6. Immigration, customs, they interface with people, and so on. Parliamentarians, local government councillors, local government practitioners will be under the rubric of essential workers. And to show you how we make the distinction, I was on a radio program last week, and somebody was asking about security guards. High risk, high exposure. A security guard in a hospital versus a security guard managing a warehouse in an industrial complex who is not exposed to the public. You would give your last dose to a security guard in a hospital setting versus a security guard in an industrial complex. So the principle is high risk, high exposure. And then phase 3, the public over 18 excluding for the present, because we don't have data as yet on persons under 18 and pregnant women. Trials are continuing with that. We have already identified some mass vaccination sites, and that is when we will engage NGOs like the TTMA and other NGOs to vaccinate persons in the public domain, regardless of risk and regardless of exposure. Now, if, as we expect, more and more vaccines become accessible to Trinidad and Tobago, as more and more vaccines are approved by WHO, and as the bigger countries vaccinate their local populations, therefore more millions of doses become available, if we get large amounts of vaccines, let's say 500,000 or 1 million, which we can store, then we may not go sequentially, but then open it up to the general public. So the vaccination plan is predicated on getting vaccines approved by WHO, manufactured in sites approved by WHO. As I close, I want to assure the public that you will always get true information from the Ministry of Health. I urge the public to ignore the propaganda being put out there. We at the Ministry of Health, we are ready and willing to accept WHO-approved vaccines so we could administer it in a carefully thought-out program so that you, the members of the public, could be assured of safety and efficacy. And I will give you the assurance now, we will not be engaging in shortcuts by bringing in vaccines that are not WHO approved or manufactured at sites that are not WHO approved. Shortcuts will not help us in the long term. It may make us popular in the short term, but we have your health, your safety as our #1 priority. So I hope we have given you this morning all the elements of a careful, well thought out, safe vaccination program. And Candice, I thank you, and back over to you.
Thank you very much, Minister. And we go now to the question and answer segment and begin with questions from CNC3, please.
Hi, morning everyone. Rashad Khan, Guardian Media Limited. Okay, so my first question is to Dr. Carrington. Dr. Carrington, you are currently conducting genomic sequencing on samples and stuff, and we would have mentioned the variants of concern. But well, first of all, how many samples have you tested so far? And outside of variants of concern, are there any inkling that the virus in circulation in Trinidad and Tobago may be more than one specific type? And secondly, I would like all three panelists to weigh in on this. Dr. Carrington, you mentioned that there is some promising evidence coming forward about the vaccinations reducing transmission. So how good is that evidence? And for the CMO, how do you anticipate that this could play into our quarantining of especially repatriated nationals? And for Minister, at the policy level, what would it take for that quarantining period to probably be reduced in light of this evidence?
Thank you, Rashad Khan. Quite a few questions thrown in there.
Start with Dr. Carrington.
And so we go to Professor Carrington to respond to the first of your questions.
Thank you very much. So your question was about the sequencing that we've been doing and whether we have been seeing how many samples we've done and whether we've been seeing any other lineages in Trinidad and Tobago. So to date, we've done about 300 samples from across the region. And of those, 150 are from Trinidad. So we've generated sequences from 150 different viruses. And as I said, to date, we've only seen one example of UK variant in a quarantined individual, one example of the Brazilian variant in an individual on a ship who did not come to shore. Amongst the other lineages that we've identified, there are several lineages that we've identified. I hesitate to give you a number for Trinidad alone because I don't have that data with me, but across the region, we have identified 48 different lineages. So remember, as I said, the vast majority of these have, they have mutations that differentiate them from the original virus, but those mutations have no major impact on the virus's properties. So yeah, so there are many. I can't give you the number in Trinidad. It's probably like about 7 or 9 that we've seen over the months that we're doing. But I won't. Don't hold me to a number. I'll have to get that. The other thing you asked about was transmission, the impact of vaccines on transmission. Now, what's been the study I was thinking of is one, I believe, was the Astrazeneca vaccine, where they, in vaccinated people, they took swabs, regular swabs, to see if the person was PCR positive for the virus. Now, remember, you can be infected and show no signs of disease. So in order to know if somebody's infected, you can't look at them and say, do you have symptoms? You have to actually go and test for the virus. So that's what they were doing. And if I recall rightly, they saw about a 60-something% reduction in the presence of the virus in the vaccinated people versus the unvaccinated. And so we feel that it's going to reduce transmission. There are some other studies where they actually looked at contacts of vaccinated people that also showed a drop in transmission rates. And I believe it's also been shown for Pfizer. I think Pfizer did some studies as well. So yes, it's good evidence. It's not zero transmission, but it's good evidence that it does bring down transmission significantly. And I can't remember the next question.
Yeah, so in terms of the impact of what Professor Carrington has said to us, and we discussed this before on the press conference. So it is 67% decrease in the transmissibility has been shown by nasopharyngeal swabs during the AstraZeneca study, for example, meaning that 33% of those individuals will still be infected with whatever virus goes around. And that is a significant risk for even AstraZeneca alone. Pfizer had an ongoing study in Argentina, I believe. The other vaccines have not been significantly studied in the way of that AstraZeneca and Pfizer are doing with regards to the infectivity of persons who would have been vaccinated. And it's a little bit early to change our quarantine stance with the data not being out, one, and even with the data with AstraZeneca, for example. It means that 1 in 3 persons have the potential of being infected. And if you think about a repatriated group, for example, of 100 or 300 people, that means 33% of them, if all of them would have gotten AstraZeneca, still have the potential to have the nasopharynx infected with a virus and potentially spread that. Hence the reason we maintain the quarantine position, 14 days at this point in time, 7 in a state quarantine facility and 7 outside in home, until further evidence comes forward and we are able to look at the position or change that position. But for now, the position remains the same.
So the third question is to me, although the CMO answered it, from my position as Minister of Health, I will be advising when decisions have to be made that the quarantine period for the safety of citizens of Trinidad and Tobago, for the safety of all of us, the Trinidad and Tobago model, which is a careful, conservative model, has worked in saving lives. And we will continue with that position until the evidence indicates otherwise.
Thank you. And we go now to 98.1, please.
Good morning to the panel again, Ms. Candice Alcantara, Minister Dialsing, Professor Carrington, and of course the other member of the panel, Dr. Parasram. Stephen Cummings here, 98.1 FM. My 2 quick questions, one for Minister Dialsing and the other for Dr. Parasram. I begin with Minister Dialsing. Minister, you gave a very comprehensive, I would think, report there on the plan and the vaccine rollout. But I have a question. Is Trinidad and Tobago in any official talks at this time with the IDB with respect to a new vaccine security instrument? I believe the IDB is now supporting Caribbean countries outside of COVAX to negotiate faster access. It talks about a guaranteed instrument aimed at improving the terms and conditions on which vaccines are delivered. Now, the IDB president is also quoted as saying that the ability to receive and distribute vaccines is a race that will largely determine the economic and social future of countries around the world. And the question is to you, Minister, is Trinidad and Tobago in any official talks with the IDB at this time? And Dr. Parasram, while there is little argument against the science and the WHO that AstraZeneca is safe, it appears that more countries are exercising precautionary measures, one, the latest being New Zealand, I saw only yesterday. Does this create more anxiety and perhaps a heightened level of uncertainty among ministry officials as to what should be done now or at this time in light of anticipated shipments of the vaccines? It may not only be in the case of AstraZeneca. Thank you.
Okay, so thank you for your two questions. So I'll give you the answer. Yes, IDB, we do have an arrangement with IDB for funding of vaccines. And also, as I stated before, we do have a funding arrangement with CARPHA using an EU grant for vaccines. So the answer is yes to both IDB and CARPHA. And the question about a race. We cannot be too quick to bring unapproved vaccines into Trinidad and Tobago. You may win a race to start. You may look good in the short term. But what happens if you have an unfortunate adverse event because the Minister of Health wanted to win a race, wrongly advised the government to bring in a WHO unapproved vaccine, and you have an adverse event? So from my perspective, I am not viewing this as a race. I am viewing this as a sound policy decision to vaccinate persons with a vaccine that the population could have confidence in. Right? So I hope that answers your question, Mr. Cummins.
And the second question was directed at CMO, please.
Okay, yeah. So speaking again about the as Minister would have indicated earlier, that process is ongoing for review, both by the European Medical Association as well as the World Health Organization, that because the incident would have occurred within those territories, and we await their go-ahead to proceed. Countries are free as sovereign countries to take whatever precautionary measures they want to do to safeguard the health and safety of their population. And if it is that they have ceased pending EMA and WHO authorization to proceed, then that's all within their right.
Let me just come in here again, because we have a small country of 1.4 million persons. Suppose, as Minister of Health, I advise the government to bring in a vaccine because of short-term pressure to start a vaccination program. And we bring it in from a non-WHO approved source and or site. And you have one adverse event versus a continent with 300 and 400 million persons with one adverse event. They could absorb that type of shock, but we can't. So I understand, but in the interest of protecting the health of our population, we will be careful, and the Trinidad and Tobago model of being conservative and careful has worked for us. Let us continue treading a very straight and narrow path as we start our vaccination program within 3 to 5 days once the vaccines are in Trinidad and Tobago, so we could all have confidence in the vaccines.
Thank you. And we go now to Wired 868, please.
Hi, good morning, everyone. Fiola Bostic, Wired 868. My first quick question is to Dr. Carrington. Dr. Carrington, the B13241 variant that has been found in Antigua or from Antigua, was it found in the UK? So do we know whether it originated in Antigua in the Caribbean or whether it originated in the UK? And whether or not we've seen that in our samples that UE has been testing. So that's my first question. My second question to Minister. Minister, some of the shortages globally has been blamed on countries securing vaccines prior to their approval, in anticipation of their approval. Are there any vaccines that we can identify that possibly we may not start rolling out, but we can order before approval is found? Thanks.
Thank you. So, Fiola, I will take your question. That's an excellent question to ask. So, the fact that we have been in talks with countries and vaccine manufacturers since October means that we are willing and ready to talk to anyone. However, the final hurdle, as we have told everyone, is that your vaccine must be WHO approved. So we will have talks, we may place indicative orders, but no firm commitment is made with any country and or vaccine manufacturer until we receive WHO approval. Okay? So I hope that answers your question.
Thank you, Minister. And we go to Professor Carrington to respond to the other question.
Thank you so much. So your question is about the variant that was found in the UK recently that was associated with travelers from Antigua. So yes, it was detected in the UK, and it was detected in people who had traveled to Antigua. So so far, we have only received 4 samples from Antigua. 2 of them were from December, 2 of them were quite recently. Of those 4, I think 1 from December and 1 recently yielded, we got good test results, and neither of them were variants of concern. So I assume the next step would be to look at more samples from Antigua to see if that variant is really spreading in Antigua or if they got it somewhere else. It's important to note that these are variants under investigation, so we don't know yet if they, although they have some of the hallmarks, we don't know yet how worried we should be. Thank you.
Thank you very much. And we go now to TV6, please.
Hi, good morning. Alicia Boucher from TV6 here. I have 2 questions. The first one is, Minister, I'm not sure, or Dr. Parasram, if you can, provide some clarity, but I was wondering, isn't the formula for AstraZeneca the same regardless of which plant it is being manufactured in? That's the first question. So I'm not sure whether you've had conversations with WHO to clarify that. And the second question is, it was a few weeks ago, I believe, Minister Dialsing, both you and the Prime Minister indicated that the reason why you were sticking to WHO, well, one of the reasons is that if you go outside of that and something happens, the country could be in a lot of litigation. And I was wondering, given that WHO did approve the Pfizer vaccine and we did see some adverse reaction in some persons, should something similar happen with a vaccine that we bring in, what does that WHO guarantee give us in terms of litigation? Is it that you could litigate against the WHO? What difference is it as opposed to bringing in a vaccine that's FDA approved in terms of possible litigation? Thank you.
So thanks for asking the question. You may recall when I was here, not last Saturday, the Saturday before, when I explained the steps that we have to go through as a country to access vaccines through COVAX. I gave you all the steps, and I said one of the steps was an indemnification agreement, which Cabinet had to sign off on, and that answers your question. Sourcing vaccines for Trinidad and Tobago for COVID is not a simple thing like sourcing paracetamol, which has been manufactured for 100 years, and you have 1,000 manufacturers, and you have all of these things in place. We are going to safeguard the public as much as humanly possible. And that is why when I was here 2 Saturdays ago, I spoke to the fact that before we could have signed off on the Astrazeneca vaccines via COVAX, we had to sign an indemnification agreement, which gives us certain rights and responsibilities and puts certain responsibilities on the manufacturer in case they manufacture a bad batch. It is not as easy as persons are making it out to be, that you just buy vaccines and bring it in. That will be a dereliction of duty. And as Minister of Health, I will not be advising the government to go that path. I will now hand you over to the CMO to talk about the formula.
Yeah, so it is that all formulations will be the same in terms of the technical data that is required to put together a vaccine. So if you want, the ingredients will be the same, the processes should be the same, and what happens in every single plant that WHO approves is there is a site visit that is done. So the WHO team actually visits the plant that is going to manufacture the vaccines, and there are certain technical requirements that they would look out for, making sure that the plant is capable by way of capacity and by way of technical infrastructure as well, to ensure that that end product is exactly as it was meant to be. So as part and parcel of the WHO approval process, they will go to the plants. So having if you're having a blueprint for something doesn't necessarily mean at the end of the process you're going to get what is printed based on the ingredients. There are a lot of steps in the way that can actually turn your end product into something else. Leaving out a excipient or some sort of other part of the vaccine can cause the vaccine to be not what is intended to be. So they have to look at the human resource that is in the plant. They look at the organizational structure. They make sure the right sort of persons are hired to do the job in different phases, and they look at the entire process from start to end. And they also look at the finished product by way of examination, looking at the chemistry of it to make sure that the components therein are what is intended as well. So it's a very rigorous process, and it requires on-the-ground assessment. So not every plant that applies for it will be approved. Certain things may be wanted that is different, or the plant itself may not meet the standards that are required.
Let me just expand on what the CMO has said, because I don't want the population to get the impression, as I have said before, that we are doing these things for the first time. Normal, established procedure for authorizing drugs in Trinidad and Tobago, which the minister signs off on after the Drug Advisory Committee makes their recommendation, is not only the drug, the label, the site that is manufactured, and the process. There is something called in the manufacturing world GMP, good manufacturing process. Because you have a formula, it doesn't mean that all sites adhere to the formula. And every time a local agent has a drug that is now being manufactured at another site, they have to make a supplemental application to Chemistry, Food and Drugs that the minister signs off on, that this new site is certified. If a label is changed, they make a supplemental application for change of label. If the process is changed, they make a supplemental application for change of process. All of this already exists to protect the person, to protect the consumer who is taking the drug. So yes, you have a standardized formula. Let me use a local example. I could give 3 people the same formula to make black cake or pancha creme. But different people do things differently, add different things in different sequences. Having the same formula does not mean that you will get the same end product. So, to answer your question again, we not only approved the formula, you also have to approve the process and the plant, as we currently do. And I sign off on change of plant, change of label, change of process, well, not every day, whenever a local drug manufacturer makes that application. All of this is to ensure safety of the drug being used, and the same will apply to vaccines. But that was an excellent question to ask, and I thank you for it.
Thank you. We go now to ACP News, please.
Hi, good morning. Priya Bihari, acpnews.com. I just have one question for the Minister. Minister, when the time comes to the rollout, if an individual says he doesn't want to take the Astrazeneca vaccine, for example, and he says, okay, I'll wait maybe on Pfizer, maybe Johnson & Johnson, what is the ministry's policy regarding that? In other words, how much choice does the individual has in terms of what vaccine he gets?
Thank you.
Thank you.
Thank you, Priya. So that question has been asked globally. The response is, one, we cannot mandate that anybody take any vaccine. However, at this stage, because of how things are uncertain, the advice to people is a bird in the hand is worth two in the bush. The advice is, if a particular vaccine is available to an individual, take it now, because the global supply chain is so uncertain at this time. If you have a vaccine of choice, you may or may not get it. So Priya, that is a question that's been asked globally, and the global advice is take it while you can get it. Okay, thank you very much.
Thank you very much, Minister. And we're close to the end of time, so please, 2 brief questions from Express.
Good morning, Kim Bodram from the Express. Minister, I want to ask you to maybe repeat yourself a little bit and go back and just tell us again, when it comes to the actual negotiations, the people or the agencies doing the speaking to, not just WHO and COVAX, but the actual companies themselves. Can you remind us who are the people and agencies involved that do the negotiating and the contacting? And also, is there any room or any consideration, and if this happened already, please forgive me, the feed was a little bad, in terms of another body being added on or an entity to do that negotiating as well, so that government could maybe pursue it as aggressively as possible, be as omnipresent as it can be on the world market, looking, searching, securing. I hope I asked that as sensibly as I could. Thank you.
Yes, Kim, you asked it very sensibly. So vaccine manufacturers and or countries have stated that they will only deal with governments at this point in time. They are not selling to or dealing with third parties, even though they have a local distributor in country. So if you are pursuing bilateral talks with any vaccine manufacturer, they are not speaking to a local distributor. They are only speaking to governments. The 2 entities that represent the government in talks are the Ministry of Health and the Ministry of Foreign and CARICOM Affairs. Vaccine manufacturers have made it clear at this point in time they are only dealing and negotiating with and or selling to governments. No third party, no local agent, and they will not entertain anyone except a bona fide representative of a government. So that was a very, very well put, Kim.
Thank you very much, Minister. We have come to the end of today's media conference. And just a reminder, please continue to follow the 3 W's. Wash your hands, watch your distance, and of course, wear your mask.